we've seen that the presence of FLT3 changed over time because with FLT3 inhibitors, especially Myeloid, for which we have yet mature data, which change the prognosis, because those with high allelic ratio fared better than in the past, and therefore in the new classifications they are classified as intermediate risk. So if you have a FLT3 mutation in case of relapse refractory patients, you need to use a FLT3 inhibitor. We've seen that, for instance, with IDH1 inhibitor, if you treat relapse refractory AML with an IDH1 mutation without a FLT3 inhibitor, the response rate is really very, very low. Therefore, it is crucial to have a FLT3 inhibitor. Frontline, we've seen that either Midostaurin or Quizartinib for FLT3 ATD patients impressively improve the outcome of these patients. So you need to take into account FLT3 as an intermediate risk factor with intensive chemo, treat these patients with FLT3 inhibitor and stem cell transplant, followed by maintenance at least. This is what we've seen with Sorafenib or Gilteritinib for those who have relapsed refractory patients and have been transplanted. For the elderly population, it makes sense to treat patients with FLT3 inhibitors also, along with Ven or Veneza whenever possible, because it leads to better response rates, and we hope that it will translate into better overall survival in the next future, at least the triplet possibilities. Thank you.